Welcome, Oakland County EMS providers, to Section 9. We have Dr. Steve McGraw with us today. He's our medical director. Bonnie Kincaid, she's our executive director of the OCMCA. And me, John Toit, the EMS system manager. Before we get to Dr. McGraw and Bonnie, I just want to tell you some notes about Section 9. 9.102, which is the MFR-BLS Opioid Overdose Naloxone Administration Protocol, is on hold right now. It's being reviewed by the state of Michigan and the Oakland County Medical Control Authority Protocols Committee. And another note, this one's a big note. The medications are no longer in protocol in this section. All of the medications have been removed. They are no longer protocols. We will make them available in a separate part of the website as references. Thank you.
So Section 9, we got Dr. McGraw here to help us through the changes that are in Section 9. Got Bonnie and John here also. Section 9.1, Medication Administration. Dr. McGraw, what are your thoughts?
Well, you know, we've really put this in a situation where it's not a protocol anymore. And in fact, it's sort of a reference list. There's reasons for that, and we'll get into as we detail a little bit. But the clarity is a little bit of appealing to me. Just the caveat, though, is you're going to read a lot in this particular list and protocol that is essentially training. And I'm not saying disregard it, but know that this wasn't our choice. People that know us know that I've tried to keep training as much as I can out of our protocols so that they're useful. But as we've reconciled our protocols with the state, there were some things that just were compulsory. Here's a good example of what I like. We do indicate what the process is for giving intranasal medication. And you all should know that this is a very effective way to administer medications you don't have an IV. So while I like it, and I approve it for even MFR, I don't necessarily need you to see how to put the hand behind the head and how to insert an atomizer into the nasal aperture and stuff like that. I think you're all capable of doing that and do it well. Nonetheless, this then is not so much a protocol, but rather a reference body. Nebulized medications, of course, a great way to administer medications in our system for our levels is with a nebulizer, and you all know how to use it. While it's not approved for anyone but ALS in our system, there's the procedure to how to follow it, and with the additional caution for pediatric patients that will often need help with the mask.
And this used to be its own protocol, which is nice now that it's one protocol rather than two.
And it covers all the medicine.
Absolutely. Now, the medication substitution protocol. Bonnie, when we were talking about doing this, you had a great way of phrasing the importance of this protocol for the providers.
It's really more for the hospital pharmacists. This protocol is not so much about providers as it is hospital pharmacy. And as you see the list, our current medications, that's the ones that we carry, but the substitutions, we don't even carry them, nor will hospitals put those in the drug box. So we're going to take this back to protocols and take it through our process again and see if we can get that chart taken off or making something a little bit more sense put in.
Yeah, because it's information you don't need if you're never going to see those medicines.
And really, if we just look at the box, if there's a sticker on the box,
yep,
there's a change.
It pre-warns you that what's inside is not what you expect.
And for Oakland County, it's normally a pink sticker, but it could be a different color sticker. So just pay attention to the top of the box before you open it.
Yeah, a little comment about outsourced medications. Just knowing what the expiration date and being certain that if this is the way you have outsourced, that you're responsible for their storage.
And again, this is another protocol more for hospitals and the pharmacy than EMS.
There's really no change to this protocol as you go through it other than the outsourced medications.
It's reassuring to know that the medications and their utility hasn't changed much, and we can focus on the few changes that there are. For personal meter dose inhaler use, these are patients with respiratory distress and who may likely have a viral infection. The notion is to allow them to use, with your assistance, their meter dose inhaler, their little puffer, with or without a spacer, could provide additional safety to responders because when we give them a nebulized treatment, of course, the exhaled, atomized, aerosolized medications that come out of the nebulizer mouthpiece kind of going all over the place. Whereas in an albuterol meter dose inhaler, the little puffer with a spacer, plus or minus a spacer, it's really somewhat self-contained and you're not as likely to be encountering any of those viral particles. A lot of training again in figure 1 there, where she's actually using a spacer and all the ways to do so. Suffice to say, spacers are fine, but if they don't have it, just using the meter dose inhaler is excellent.
So protocols 9.5 and 9.6 didn't change. We're just going to scroll through those kind of fast so you can see that there really was no change there.
Again, these are more for the hospitals and the pharmacists. And when we get to the exchange protocol for the actual drug box, then this is a good protocol to read through as a provider, as a paramedic, just to know what your responsibilities are for that drug box. And then again, there's a lot there for the pharmacy as well. But make sure you do read, the ALS crew will, and box cleaning and expiration, that type of thing is really important for the paramedic.
Our pharmacists are all about rules, you guys, and we have to do our best to agree to them because the pharmacy laws still apply to us, even in the pre-hospital world. You can always tell a pharmacist is behind it because they have a lot of words. They type more than any emergency physician I know, but they're not for nothing, and the rules are there.
And then just so you know, one drug will be added to this list in the near future, probably by March 1st, and that's going to be an antibiotic. And Dr. McGraw can talk about why that antibiotic is going in there, but we are not going to be utilizing it in a protocol for Oakland County.
The layout in the box, where you should find the medicine and where the hospitals are responsible for placing it.
And then another thing just to know that in this section, we used to have a lot of medication protocols. And they talked about indications, contraindications, dosing, that type of thing for adults and pediatrics. We have taken all of those out of our protocols completely and made them more like guidelines. You won't even see them in our protocols. And so that's just something to be aware of. You're not going to find dosing in this section now of any particular drug. You need to go to the treatment protocols to find the dosing.
Excellent point. This section 9.7 really is for those utilizing, well, EpiPen is the brand name, but an epinephrine autoinjector, including MFR agencies. This is just the protocol that indicates how it's to be used and under what conditions.
And again, there's no change to this protocol from the previous version. And this is the Narcan Leave Behind program.
We only currently have 2 agencies that are utilizing this protocol. Any other agency that wants to join in, we certainly can add you to the list. And as long as you have a hospital that's going to partake in this program.
Medications under direct medical control use. Dr. McGraw.
Yeah, we're part of a regional system, you guys, and some parts of the region have very long transport times. So for things like open long bone fractures, imagine a femur coming through the tissue on the anterior thigh, or an open tib-fib fracture, or an open both bones forearm fracture. They really believe that there's a justification for administering antibiotics, specifically cefazolin or ceftriaxone, en route to the hospital. Mind you, there's some literature that supports if you're going to give antibiotics for these very terrible orthopedic injuries, the sooner you give the antibiotics, the better. Myself and the rest of Oakland County's providers and physicians really, however, don't believe our transport times justify you having to spend the time to reconstitute, hang, and administer these antibiotics when you're not too far from a level 2 or level 1 trauma center anywhere in our Oakland County MCA. If you ask to give it for a long bone open fracture, you'll get permission after radio. But just as a little editorial note, if someone has enough energy in their injury from their either a motor vehicle crash or their fall to have their long bones get broken and puncture through the skin, there's a really good chance that there's other manifestations of that same amount of energy. A broken pelvis, a pneumothorax, a ruptured spleen, a head injury with airway management issues. All of those, to me, need your attention and that of your colleagues in the pre-hospital field, more than you having to calculate and mix up, rehydrate, and administer antibiotic doses that really we have pre-made for us in the resuscitation room at all of our trauma centers. And we'll infuse right when we give their tetanus shot and something for pain. If you really feel compelled, you have the thigh bone sticking out of the skin, you're seemingly a long way from a level 2 trauma center in our system, you'll have the medication. You can always ask for it to be given, but I would ask you to only do that when you've really satisfied to yourself that there's no additional IV access that's needed. They don't need any medications for pain. Their oxygenation level is perfect. They don't need any assisted ventilations. And there isn't any other injury you have to be seeking out, like intra-abdominal ruptured viscera or lacerated liver or spleen, or a pelvic fracture causing massive blood loss in the retroperitoneal space. And you should be using a pelvic binder. I would rather you spend the time thinking about whether or not to use a pelvic binder as opposed to having to draw up and administer an antibiotic we can give even easier at the hospital.
So the next protocol, 9.101, that is the MFR and EMT medication exchange protocol. We used to have this protocol in 2 places. We've combined it into one, so you can have all your Epi and Narcan needs right here in one spot. There's been no change to this protocol. As we scroll through it, protocol 9.102 is the MFR-BLS opioid overdose Naloxone administration protocol. It's not ready for the training as of yet. It's still being reviewed by the Oakland County Medical Control Authority in the state of Michigan. We intend for no changes to occur to that protocol, and we are working with the state to work out any issues they might have with it. And so that's the end of section 9.
Wow, thank you both very much. I really appreciate everything that you folks do to our system and for our community. And if you have any questions, don't ever hesitate to reach out. We can be reached by email, and we're all going to get used to some of these new changes. Fortunately, they're not catastrophic. And I'm really proud of all the work that you do every single day to help our community.
Well, thank you, Dr. McGraw, for coming. Thank you, Bonnie.
Thank you, John.
Thank you for listening in on section 9. Next section is the section that you guys have been looking for, section 10. It's the last section.